Hello, welcome to this lecture on Towards Painfree Hospital Implementation in Emergency Department. Do you know that pain is the most common reason for patient visits to ED? Pain is the chief complaint up to 78% of the time. Now, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damages. Now, essentially, what it means for the healthcare workers is that pain is unpleasant, it involves emotions, and the cause is not always visible. Now, severe acute pain can cause multiple adverse effects. For example, if a person is having severe pain, there is an increased sympathetic activity, and that causes the heart rate to raise. In a person with existing ischemic heart disease, where his myocardial supply is limited, this will mean that there will be a tipping of a myocardial oxygen demand, which can lead to myocardial infarction. Another example for severe acute pain is the psychological effect, where it causes anxiety and fear, and that causes sleeplessness and helplessness, and eventually causes psychological stress. That is why Ministry of Health of Malaysia is pushing forward for pain-free hospital implementation. There is three main components of pain-free program, namely anesthesia and analgesia, modern surgical techniques, and traditional and complementary medicine. The objective of pain-free hospital includes pain-free surgery, pain-free labor, pain-free procedure, pain-free rehabilitation, and pain-free discharge. Out of these, pain-free procedure and pain-free discharge is the more relevant items for emergency department implementation. There are 10 criteria for accreditation of pain-free hospital. Number 1 is a written policy. Number 2, implementation of pain as fifth vital sign. Number 3, standardized treatment protocol for acute pain. Number 4, all healthcare staff trained. Number 5, patient education and involvement in their pain management. Number 6, regular audits on pain assessment and management. Number 7, policies and guidelines on minimally invasive surgery. Number 8, policies and guidelines on daycare surgery. Number 9, multidisciplinary team approach. And number 10, incorporate non-pharmacological and traditional or complementary medicine. If you look at all 10 of the criteria, number 7 and 8, which is the minimal invasive surgery and daycare surgery, is not too relevant to our emergency department practice. I'm going to go through each of these criteria shortly. So for written policies, Ministry of Health policy statement on pain-free program includes number 1, pain is one of the vital signs. Number 2, pain is assessed in all patients. Number 3, a standardized pain assessment tool must be applied consistently. And number 4, healthcare providers should listen and respond promptly to patient reports of pain and manage pain appropriately. And number 5, healthcare facility staff should be continually educated and aware of pain assessment and management. There is also written policy of pain management under the patient charter, which includes provision of pain-free experience, treatment of pain from all conditions, prompt management of patient within 1 hour, assessment by trained professionals, and pain control tailored individually with appropriate medication as well as non-pharmacological methods. The pain-free policies are displayed at the pain-free corner in different zones. This is the pain-free corner of the green zone in our emergency department, which is situated next to room number 1. This is the pain-free corner in the yellow zone near the pediatric bay. The pain-free reference material is located in the document room. This is the document room. The pain-free reference material is located on top of the shelf in this red color folder. The material includes 5 booklets. Otherwise, the pain-free file is located at the lower shelf with a purple color label. Now let's talk about implementation of pain as fifth vital signs. In 2008, Ministry of Health Malaysia has made pain as the fifth vital sign as a nationwide policy. That means, in addition to temperature, pulse rate, respiratory rate, and blood pressure, pain score is the fifth important vital sign. For these, we have placed pain assessment tool at strategic location in secondary triage, in green zone, in yellow zone, and OW. Talking about standardized protocol, a standardized model is used for management of pain, which is the RAT model. RAT stands for R, recognize, A, to assess, and T, to treat. Who should we assess for pain? We should assess all patients. That includes all the patients in the emergency department, in the recovery room of operating theatres, in the labor room, ambulatory daycare units, wards, ICU, HDU, CCU, and even clinics. Who does the pain assessment? All of the hospital staff should do it. That includes nurses and paramedics, or doctors, allied health personnel, and healthcare trainee like medical or nursing students. Now, when should pain be assessed? Pain should be assessed on scheduled observation during vital sign taking at regular interval. For example, every 4 hourly or every 6 hourly. Beside the scheduled observation, pain should be assessed on admission of the patient, on transfer of patient, or whenever a patient complains of pain. Now, if you have given a treatment or intervention for pain relief, pain assessment should be done half to 1 hour after analgesia or nursing intervention for pain relief. Pain also should be assessed during and after any painful procedure. For example, during and after wound dressing. Now, why is it important? This is because if we are able to assess pain, we will be able to set the pain score as the baseline for our intervention or treatment. Knowing the pain severity also facilitates communication between staff looking after the patient, and it is also easier for documentation. So how do we assess pain? First, we need to listen and believe the patient. Take the pain history by an open-end question like, tell me about your pain. From this question, we are looking for the site of pain, what is the aggravating factors, how is the intensity of the pain, what is its nature, and what is the neutralizing factors. Now on to the clinical techniques for measurements of pain. There are 2 main types of pain measurement: the self-reporting and the observer assessment. Self-reporting pain measurement is done by the patient. It is the gold standard of pain measurement, hence it is the best method. Observer assessment is done by the staff. It is done by looking at the behavior and taking consideration of the vital signs. It is a kind of functional assessment. Now, to assess pain, we need some tools. How do we select a good pain assessment tool? We should select a standard tool for pain assessment, and we should use an appropriate scale. When doing assessment, the tool must be appropriate for the age, learning, and development of the patient. And we should always use the same tool for the same patient for consistency. Here is an example of the suitable pain assessment tool for different age group. For adults with normal cognition, we can use the Ministry of Health Pain Scale. For those with impaired cognition, we can use the FACE scale or the FLACC scale. For pediatrics patient aged between 1 month to 3 years, where the patient could not communicate their pain well, an observer assessment tool like FLACC scale should be used. For pediatric patients aged between 3 years to 7 years who are able to communicate, especially via graphical manner, we can use the FACE scale. For patients more than 7 years who can speak well, we can use the Ministry of Health Pain Scale. This is the Ministry of Health Pain Scale. There is a label of 0 to 10 with a slider. To use this tool, we ask the patient to rate the pain on the scale of 0 to 10 and explain that 0 is no pain and 10 is the worst pain one can imagine. And then the patient is asked to slide the indicator along the scale to the pain that they are experiencing, and then we will record the pain as number. In this slide, we can see the FACE scale. The top one is the Ministry of Health FACE scale, which is adapted to the scale of 0 to 10, whereas the lower one is the Wong-Baker FACE scale with the scale of 0 to 5. We are using the MOH FACE scale with the scale of 10. This is suitable for children between 3 to 7 years old or cognitive impaired patient. Patient is asked to point on the face representing his current pain, and we will record the pain as number. For FLACC scale, which is an observer assessment scale, we observe the behavior by looking at the face, leg, activity, the cry, and consolability. Each of the category is scored from 0 to 2, which the results in total will be scored between 0 to 10. For example, for children with the face showing no particular expression or are able to smile, we will give the score of 0, whereas a child with occasional grimace or frown will be given 1 mark. Sometimes there are patients who are unable to be assessed. For example, a patient who is sedated or unconscious. We will record this as unable to assess or unable to score. To manage the pain, we have 2 main methods: pharmacological and non-drugs methods. Pharmacological agents include non-opioids, opioids, and anti-neuropathics. For pharmacological management, we use the analgesic ladder to decide what medication is appropriate for the pain score. As for the staff training, we organize regular Painfree CME or CNE, and currently we are using online CME through WhatsApp video. For patient education, our staff should explain about pain assessment tool and how to use them. Otherwise, they should also explain to the patient when to alert us when experiencing pain. Now, talking about regular audits, audits are done on nurses and paramedics with a standardized audits form. Here we can see that it is a requirement to smile and greet and acknowledge patient, explain the purpose of pain assessment ruler, and teach the patient to give pain score. And if it is necessary, to reteach them how to use it. The audits for nurses and paramedics also includes a section where the pain score is less than 4, where the staff are required to document the pain score and follow the pain flow chart for nursing action and carry them out, and also to ask whether the patient is comfortable or needs any medication. The nurses also need to inform the patient to alert them if pain score increases. Nursing action should be documented. Another section is for the pain score of more than 4. The pain score should be documented and check for doctor's prescription audit. Check the time of the last dose of analgesia and serve the medication as prescribed, or carry out nursing action as required. If analgesic is not ordered, the nurses or paramedic should inform the doctor, record pain analgesic after serving, and reassess pain score after 30 minutes to 1 hour and document them. And lastly, a general section for all pain score is to advise the patient to inform if pain increases, to listen and respond promptly and politely to patient's question, and to give reassurance if patient require medication and medication has not been prescribed. Lastly, accurate and complete documentation. As for audits of doctors, this is the standardized question checklist. Among it, the doctor should know where the reference documents is located in the department, and as for the interaction with the patient, they should assess the pain score of the patient, explain about the degree or severity of pain to the patient, make sure that the patient inform the doctors about their pain and document it. For the pain score of more than 4, to reassess after 1 to 4 hours after treatment. This is the patient's questionnaire, consists of 6 questions. The patient is asked whether our nurses perform pain assessment on admission and during their stay. The patient is also asked if explanation given on pain assessment and treatment were easily understood. Then the patient will be given opportunity to express whether pain treatment is adequate and whether pain assessment is important for their comfort. They will evaluate pain management received in different areas and whether they are satisfied with the overall pain treatment in these facilities. Next, about multidisciplinary approach on pain management. Pain management should involve multiple disciplines, including doctors, paramedics, pharmacists, physiotherapists, and etc. And lastly, about including non-pharmacological, traditional, or complementary medicine in pain management. For non-drug treatments, it includes physical treatment and psychological treatment. Physical treatment includes physical support, immobilization, compression, ice, elevation, massage, hydrotherapy, acupuncture, and TENS. For psychological treatment, it includes empathy, explanation, reassurance, counseling, distraction, music, relaxation, and guided imagery. Let's take a look at some of the physical methods. For a sportsman with a knee pain, they apply ice or elevation. Massage can be done to relieve the pain. For folks with osteoarthritis, hydrotherapy is a good method of pain relief and improve joint mobility. Here is an example of acupuncture being used to relieve knee pain. And this is a TENS device to provide stimulation to the muscles. Here are some psychological methods. It is actually very effective to show the baby shark dance video to a young children to distract them from pain. Otherwise, music and relaxation are equally effective. Some designers use guided imagery such as wallpaper with soothing surrounding to ease the pain. That's all about Painfree Hospital implementation. Thank you for your attention.